to our Voices of the Field section. And so the reason for this is, from our feedback at the survey that Ebony touched upon earlier today, one of the leading concepts that came across was having further discussion about health equity. And so we wanted to have a little series, and we asked folks if they had presentations and wanted to share. Please feel free to. And we had a bunch of volunteers, including Whitney Rogers, who, as before said, that has already said that she's the social chair for our section, social media chair for our section, but she's also with Eco America Climate Health Ambassador, and will be presenting her work there in the topic. And then she'll be followed by Alison Jordan, who is co-owner of ACOJA, which is a consulting firm in New York and focused in the area of incarceration. And so I'm going to let the floor start off with Whitney, and we will have a 45-minute session, and we may go a little bit over if we have to, but we want to make sure we maximize and have good, fruitful conversation with everyone. So thank you. I'm going to stop.
All right, can you guys see my screen? We good? I'm going to show all your little faces up here. Okay. So I'm Whitney Rogers. I've been with CHPPD for a long time, APHA a little bit more. And I say a long time. I graduated in 2013, so I've been a member since at least 2013. It feels like a long time, but also feels like a nice little juvenile growing up, a summer session, I guess you will, with CHPPD. And I've loved it ever since. Like Maurice said, I am an Eco America's Climate Health Ambassador. You might have seen some emails about them pass through your APHA email as they're reaching out for ambassadors to apply. So today we're going to talk about some equitable considerations when approaching and addressing environmental issues. Some of you mentioned that you were interested in not only seeing what people are doing locally in their area, but also like the little small movements that move the needle. I saw someone submit that. I really like that analogy because essentially that's what I'm going to talk about today. Oops. Okay, I guess I'll have to click and not use my mouse. So let's talk a little bit about the climate health ambassadorships. This is kind of what brought me to the table. I do work in government, so everything that I am presenting today is on my own personal time. It's for educational purposes only, and really through the lens of Eco America and CHPPD. So no really association to any other entity. I'm not endorsing anything. I'm just simply providing information and education to you guys and hoping to engage in a conversation with you all. So the ambassadorship was created in partnership with APHA and Eco America. It offers an opportunity for people who have been in the field, who are preferably newer in the field like myself, to engage their community on a climate health objective. And so that can be anything from addressing air pollution to injustices in incarcerational health that Alison will touch on later. And so I kind of just took the plunge and looked at something that's been bothering me for a while in my hometown of Dallas, Texas, and decided to kind of talk about the overview and the plans that I have and my city has to address some of these issues and challenges we have. And so I hope that I can help you guys understand what Dallas is coming from. It's going to be a very relaxed narrative almost. I'm going to share some data that Dallas has shared with its constituents, and I'm also going to share a personal narrative from South Dallas, which is a very prominent Black historic neighborhood. There's a lot of different programs of Eco America. If you're interested, I'm going to put a little quick link in the chat that allows you to kind of just peruse the ambassadorship and gives you access to the website. They offer a lot of information, and you'll see more from Eco America, and there's a lot of opportunity there for CHPPD to collaborate with Eco America. So just keep on top of what I'm doing and making sure keeping me accountable by sharing that information with you guys when it presents itself. So we're going to talk about environmental health equity, which we've all, looked at and probably talked about before. Climate health is one of the top things on people's mind right now. Eco America sent out a survey to a couple thousand people recently. And from rural to urban districts, from independent to governmental employees, everyone has climate change and environmental health on their mind. We've seen a lot of tragic events happen in the past couple of years between Harvey and Storm Uri here in Dallas, Texas, that have really impacted our perspective. And what I get from not only myself, but also from people I love and people in my community is there's a hesitancy. There's a hesitancy in addressing it, but there's also like almost like a fear of like what's going to happen next. The winter storm really showed how vulnerable Texas is and how policy really can wreck a situation. And right now, Texas is going through a heat wave. It's a small heat wave. Everything's below 105, which in Texas, we're like, whew, thank goodness. But that's really scary. I was thinking about this morning, I'm like, I'm doing a presentation today. What if the grid just collapsed again during a heat wave, you know? And we're still kind of dealing with the after effects of that winter storm. And it really, really showcased how inequitable my city is in regards to how not only we responded to that storm, but how we're still responding to that storm. So when we're looking at health equity, it kind of, environmental health equity, it does fall under the parameter of health disparities and health equity. So when I'm looking at the KFF model of how they measure health equity through social and economic inequities, every single one of those can be touched upon with environmental health equity. Income definitely depicts how your environment is, parks, walkability, your medical bills, you know, what chronic health issues are you dealing with? How are you paying for those health issues? Are you impacted more with climate than your neighboring constituents? Do you have to pay more in order to take care of yourself due to these environmental inequities? So there's a lot of different things that we can touch upon. I'm going to try to narrow it down to a very small, narrow area of Dallas and what we're dealing with here. And then we're also going to touch about environmental health justice, who I'll get to in a minute, and how we're really kind of changing the format and the verbiage that we're using for environmental health to be more of a social active, grassroots, and justice type of motive in order to address it, because it really is kind of like push and pull and pulling teeth to get people to respond to environmental injustices. Again, use the clicker winning. There we go. So equity and equality, we've probably seen about close to a bajillion models on these different types of definitions. So equality being that everyone gets the same bike, regardless of your disability or your ability or your height or your weight or your ethnicity, everyone gets the same bike. As we can see, it leaves people out. People aren't able to perform as well. People don't have any access to the resource. But equity really models after everyone gets what they need. Now that model has its limits, because what everyone needs doesn't necessarily mean equality, because some people need more in order to survive and some people need less. And that kind of can cause some issues and some disruption in that conversation. Also, equity doesn't necessarily show, are they able to get to the bike? Are they able to afford a bike? Is that bike going to go with them throughout their life? Are they going to have a bigger bike when they grow up or become older? You know, is the bike going to match that equitability? So there's different problems with these models, but definitely we want to reach more for not only equality, but definitely equity. So the Center of Disease Control definitely defines equity in a very cubical model, I guess you can say. It's definitely talking about the preventable differences in burden of the disease, injury, violence, and opportunities to achieve optimal health that are experienced by socially disadvantaged populations. So it's a very, you know, typical CDC response to how they define that, and that we identify that there's inequitable areas, and this is how we define it. And then the CDC definitely has some different steps of how they want to achieve that, but it is more of like every city, every state for itself, how to kind of just address it in your own area. We'll give you a model to define it, but the actual action steps are depicted on your environment. Healthy people, on the other hand, 2020, which we are now in 2021, it's an overarching goal. So healthy people really thinks that every single policy, every single step that they take has to be an equitable step. And that an individual has a right to a safe and healthy and equitable environment, which I prefer that motto and that type of shaping when we're addressing it, knowing that this is a justice issue and that everyone has a right to having an environmentally healthy and equitable place to live, a place to thrive, a place for resources. So I really like that model a little bit better than the CDC. It's not saying that CDC is wrong, but I'm just saying that I do prefer the healthy people model. It's not an endorsement, just saying I prefer it. So like I was talking about, what we are looking at, especially with, decline. Let me go back to my thing. Okay, sorry, it pushed me out of my presentation. What we're really seeing with the model on addressing environmental health injustices is an equitable model. So they're trying to shape it into an environmental justice community. And APHA is one of the organizations that's really pushing that narrative, is that when we're looking at environmental equitability, we're really looking at injustices happening in our communities. So more specifically, communities that are composed of marginalized racial and ethnic groups, low income, rural areas, immigrant and refugee statuses, and indigenous populations that are disproportionately burdened, and what we can now say historically burdened by environmental hazards. When we're looking at the city of Dallas, it's always been the case. Like there's never been, oh, it was really good for them at one point. It's always been a consistent injustice to the city of Dallas and these certain populations. Dallas considers itself a open door city, so it allows refugees and immigration as long as we have federal compliance as well. So we have a really big refugee population. We have a really big marginalized ethnic and racial population, a low income population. Surprisingly, even though Dallas is a metropolitan city, we have a very big rural population. Texas is one of the biggest states per capita with rural area in comparison to Alaska. So we're like really up there with rural environments, and Dallas spreads over into some of those counties that are specifically rural. And these inequitabilities cause unhealthy land use, psychological stressors, historical traumas. They're usually targeted, these communities that are facing not only environmental justices, they're also politically targeted. They're targeted not only by what the politicians in the area are doing, they're targeted by the state politicians, and they're targeted by the police. So we know that that's a problem that we're seeing in these areas. So you have like a stack on stack on stack of issues, and all that's going into the environment. And I don't know if I mentioned this earlier, but we're talking about the microenvironment, this place that you live, but also how climate kind of places a burden on top of your overall environment. So using APHA's Health in All Policies construct, we have to address the social, the economical, and political indicators that are contributing to these inequalities. So these are two visuals from Dallas. The top one is a visual from City Hall during the Shingle Mountains movement, which I'll talk about a little bit later. And Dallas actually, I know I've had some people that I think were saying they're from Flint, Michigan. Dallas also has a lead problem. It's a bigger problem now since the Storm Uri happened, which was in February, because now we're seeing people who are having their pipes replaced, and we're seeing an increase of people reporting lead in their water, which they didn't realize beforehand, especially in the southern sectors and rural sectors of Dallas. Okay, so now that I haven't talked about Dallas enough, I'm gonna talk about Dallas some more. It's my hometown, I love it dearly. I'm very passionate about working here, which is why I'm really excited to work with Eco America and APHA and at this section to kind of tackle some of the issues. So environmental health equity in Dallas, Texas. This is a picture of Storm Uri. I know for those of you that deal with snow every year, this doesn't look like a lot. Quite honestly, this is a mere dusting. And this is before the second wave of the storm hit. And this is in the downtown area. So I live in the suburbs, but this is the downtown area. The thing is that this was really impactful because Texas isn't structured for winter weather. I used to work in the school district, and the majority of our students didn't have jackets. So when we had outdoor activities or field trips, if it was raining or cold below a certain degree, we have a policy at the school saying we can't do anything because of the impact that students don't have jackets. So that just kind of gives you a little bit of a social cue of how Texas and Dallas operates. Like people don't have winter coats, we don't have snow tires, we don't have ice tires, we only have like a few ice plows in the whole entire city, which is another inequitable problem that we have to address later. So there's a lot going on in the city, big problems. So before you start wagging your finger at us about our winter storm, let you know we were suffering pretty bad. But I'm not going to talk about the winter storm fully. But so before I get started, I really would like to take an acknowledgement that Dallas and myself lie on the traditional territory of the Caddo-Dachu tribe of the Caddo Nation. This is their land, and so we want to take acknowledgement to that everything that's happening is impacting our Indigenous communities on a grander scale. Some fun facts about Dallas. Dallas is the 9th most populated city in the US. We have about close to 1.3, actually maybe more now since the COVID move that we're seeing, million people in the city. Dallas, that's the Dallas city. Dallas is a county too, so there's Dallas City and then there's Dallas County. Dallas County kind of spans out into other counties as well. The DFW Metroplex, which includes Dallas County and Fort Worth County, our Tarrant County, is 7.5 million people, and they're estimated that that's going to skyrocket in the next 6 years, not only due to the living situation here where it's cheaper to live here, but also just generally COVID is impacting how people are moving, and so they're moving into Dallas as well as some of the other southern cities like Nashville and Atlanta and Orlando. Wallet Hub, which is kind of like a Forbes type of online platform, said that we're one of the most up and coming diverse cities. And I can attribute to that Dallas has any ethnicity, any race you could possibly think of. We're very diverse in many different ways. We have a lot of different communities that have moved here, and it's a very, like I said, a diverse city. And we're also one of the largest LGBTQA plus communities in the United States. Which I think these are all positive things because it creates a home for someone that might not get it in other places. And I mentioned earlier that we are an open door city, so we allow refugees and immigrants into our city, and we try to support them in that way as well. Okay, so Dallas did something new, which I've lived here for 30 years and I haven't seen them do this before. It kind of came with a change of hands in our mayor. They released a report, a Dallas Inequity Report. I skipped a slide. I was getting really excited. Let me move my little chat box. There we go. So this is the 2019 report, and it's Dallas's equity indicators. And we were created in partnership with the Communities Foundation of Texas, CUNY, and Center for Public Priorities. This was allowing us to kind of map where Dallas is. It hasn't really been done before on a bigger scale. So it's a public tool. So they released it to the public. It's available to anyone. Even you can find it, and I can send it to you guys if you're interested in looking at it. It's pretty plain Jane. It compares outcomes for each indicator that I've listed below between two different population groups. So that's a little bit of a limit. It doesn't really give you a full scope of overall how it compares. And I would really like to see more diversity in that, but it does kind of show you some general themes. And they use a score of 1 to 100, kind of very similar to the Healthy People's model, showing 100 showing no diversity or disparity. Just a note that this data was collected between years 2018 and 2019. So that's from the census data that pertains to that year, which doesn't include immigration. It doesn't include the LGBT population. So those two major populations in Dallas are actually not included in this. So again, it definitely negates the model a little bit smaller, which I'll kind of go into why that's kind of a problem later. So the indicators are economic opportunity. Dallas is a growing metropolitan city. They're always looking at how we're going to maximize our economy. Education, Dallas has one of the biggest school districts in the country, DISD. It's really impacting the health of others in the Dallas city, or city of Dallas, neighborhoods and infrastructure, justice and government, and public health. Again, don't touch that. Okay, so here are some of the overviews of the score. So in 2018, overall, our score is about 38.75, below 50, so not a great score, not necessarily a super low score, but not necessarily something I want to see personally as a constituent. I want to see that number much higher. In 2019, it increased a little bit, and this is all pre-COVID, so I'm sure that the next set of data, if they were to re-release this report, will look completely different. They attribute that the increase was actually significant enough that it had helped measure some of these inequities. I disagree with that, but that's okay. And then they break it down to the most pronounced disparities in the intro. They think that injustice in government for both years scored pretty low, and education scored pretty low, and I agree with that. We're a heavily policed city, And so that really causes a lot of inequities. We definitely see that Black and Hispanic individuals and immigrant individuals are arrested and incarcerated at a higher rate in the city of Dallas. They're pulled over for traffic fines at a higher rate. Education, DISDs has a lot of problems and has had continued a lot of problems. Keeping kids in school, increasing test scores, which is how Texas based its education. And then also providing resources through education. There's a huge line between the prison to school to prison pipeline in Dallas, and they've been measuring that. And there's definitely a workforce trying to tackle that. And they say that the most equitable is neighborhoods and infrastructure. They rank pretty higher than the other indicators, but there's still a lot of issues that need to be addressed. And so just a little bit of a format of Dallas, kind of to help us understand some of the other indicators we're going to talk about. Here's the city of Dallas. This is just the city, not the county. And this is the population density based off of race and ethnicity. So I want you to see that it's very, very Black and white. You have predominantly Black neighborhoods, predominantly Hispanic neighborhoods, predominantly white neighborhoods, and then kind of some mixture throughout. And if you see right here, this is the Trinity River. It's a big water source in Dallas, and it goes straight through the city diagonally. And that's going to be really important later, especially dealing with the South Dallas sector, which I'll talk about.
Wendy, I just want to give an update that we are at a 20-minute mark. So you
really?
Yeah.
Uh-oh. Okay, well, I'll go through it real quick. So public health scored pretty low, and that is between healthcare providers, health insurance, prenatal care, teen pregnancy, smoking, low birth weight. And so we scored pretty low, and that kind of shows you that environmental inequities pertains to that. So when we're looking at how equitable Dallas is on this more finite scale, we're going to look more at the narrative of Dallas. And so this is Shingle Mountain, and this is a giant mountain of roofing shingles. Here's the backyard of someone that took a picture of it. The air quality decreased with shingles. It created a lot of health effects. We actually saw that this neighborhood had a decrease in continuation of enrollment with students. So students during the pandemic actually weren't showing up for school as often as they would preferred because they were getting sick. Here's Marcia Jackson. She's the person that brought up the Shingle Mountain to City Hall. This is the city of Dallas again. And so I was talking about the Trinity River cutting through the city. This Shingle Mountain lies directly on top of a floodplain, and that's illegal in the state of Texas because we are dependent on the aquifer that this floodplain leaks into. So if something were to happen, like the Storm Uri happened, this could cause an environmental and disastrous effect. And not only that, it lied in her backyard, it was causing her health issues and her neighbors' health issues. So what can we attribute this to? First off, the city of Dallas allowed this to happen by contracting with a private contractor, and that contractor used it as an illegal dumping site. And then the city didn't want to take blame. The contractor didn't want to take blame, and they argued and argued and argued about it. And $80,000 later, the city was given back the land because the company that owned it went bankrupt. And so the city had to hire out another contractor to move it. So this is over the 4 years of the span. So that Shingle Mountain, that was about 700 tons of shingles, stood in those backyards for about 4 years. So that's 4 years of being exposed to shingles and the debris that they brought. So as you can see, that federal law and injustices really tie into someone's direct health. And if you're violating that federal law, it really helps. But imagine if this was illegal. Imagine if Marcia didn't have that federal law behind her saying that you can't dump on an aquifer, you can't dump on a floodplain. It's very scary to think of what would happen. Luckily, the Shingle Mountain was removed in March. And so the next steps that we're looking at with Marcia, she's a part of an organization that just was brought up. It's called the Southern Sector. And we're going to really target how to tackle and make that space that the Shingle Mountain was once on a park so that no one can build on it, that neighborhood is protected, it's their park, and it prevents anyone from dumping anything again. So what Dallas plans to do is that they're sharing this information publicly. They're providing a clear analysis to see how change can take place over time. This is all within their equitable report. Identify current indicators and use those to pinpoint policy Hopefully, since Shingle Mountain happened during the time that they were making this report, I don't know if they were really kind of thinking about how that merges together, and that they're saying they're doing all these things, but maybe they actually weren't. So that's something that us constituents like Marsha P. Jackson and myself are going to have to hold them accountable for, making sure they're doing things in a timely manner and that they're actually saying yes, they do. They're going to work with the community and DISD. So that's why Marsha created this organization, because according to what they want to do, she's like, well, if we have an organization that just targets turning this place into a park, then maybe we'll actually get into a park, because they say they're going to work with us. And so they're going to build parks. So we don't have anything for Shingle Mountain yet, but just recently they acquired some Trinity Forest land that is going to be kept natural, and that's in the southern sector of Dallas. And they're also going to build another park near where Marsha P. Johnson is, not in the Shingle Mountain area, but on the other side of her neighborhood. That's going to be like a transportation hub and a park for anyone that wants to use it. It's part of Dallas's 20-year plan is to create more parks and more green spaces to make the city more equitable. So kind of thinking to yourself, I know we already asked about how comfortable you are addressing City Hall or maybe your local legislators. What would you do next? You know, like now that we have the plan to create a park, what would be your next steps? APHA and Eco America have a lot of resources online to kind of contact your local government and how to specifically draft statements, and also how to talk to politicians. Identify issues in your neighborhood might be a good option. You know, where is your Shingle Mountain in your hometown? Do you have a place that you're really concerned about? How are you going to address it? How are you going to bring it up to your city hall? Visit City Hall. I would recommend, if no one's ever sat in a City Hall meeting, to go and sit at least one. That can either be your suburban City Hall or your major City Hall. Just kind of see how it goes, how it operates, how they talk to each other, what kind of language they're using, what are they addressing. And then also join us for APHA Speak for Health campaign. We have a lot planned with that in the CHPPD section. And that's a really good way to get yourself started in how to talk to constituents, how to advocate for a public health problem or an environmental problem. And I would like to acknowledge again, the Caddo Nation, Marsha Jackson, and the Southern Sector Rising, Downwinders at Risk, which provided a lot of information and images, Eco America, the City of Dallas, and the Communities Foundation of Texas. And these are my resources. So thank you, guys. I'm going to turn it over to Alison now.
And Alison, in the interest of time, how about we just jump straight to your presentation, and then we'll gauge how we want to do questions and answer following that.
That sounds great. I do have the E2 polls open for Whitney's presentation. So if you want to answer those questions while I remember which button to click to share my screen, it is open.
Great.
And I'm expecting that we have a relatively familiar audience. Can you see my screen all right there, Maurice? Hello?
Sorry, I'm saying yes to myself. Yes.
Oh, that's perfect. Thank you so much. So I have over 25 years in New York City government, so I check the government box. I'm currently representing the American Public Health Association as a governing counselor, and also as its representative to the National Commission on Correctional Health Care. They asked me to join the Academy of Correctional Health Professionals, and John Miles, who's on the call today, invited me to participate as a member of the editorial board for the Journal of Correctional Health Care. So yeah, if you don't want to talk about correctional health, just let me know and I won't bring it up, but otherwise it's likely to come up. I realized one day walking into jail after many years of knocking on doors across the state of New York that all the folks that we were most concerned about in the community were in fact the same population that was incarcerated, and I wanted to share with you why, but also mostly I wanted to share with you how we can reduce incarceration toward community approaches that are proven, that work, and that have significant opportunities to help reduce disparities. And these projects, I am disclosing to the extent that they were funded through the federal government, and they want me to make sure that you know that anything that I say is on my own and not necessarily their opinions. But we do acknowledge the funding and support, particularly from the HRSA Special Projects of National Significance, which also helped to support the e2polls.com platform. And if you are funded through Ryan White, you can receive a complimentary survey tool. And if you're not funded through Ryan White, we're going to talk more about how to get you that way so that we can continue to have conversations about the intersection of justice and incarcerated health and community health. So this is how folks feel. We're pretty much all over the board because I'm the only one doing this all the time. And so the goal would be for each of you to feel a little bit more comfortable than you do right now in discussing these topics. I'm going to slide through the slides pretty quickly, but know that they will be available, and there's lots of information and resources here. But mostly what I wanted to share with y'all is more about the how in terms of integrating some specific things that you can do in your communities to address these disparities and to make safer communities. So this is Jackie and I. We've shared this information as a pro bono experience, trying to really just raise the bar of knowledge and to remind folks that we always say correctional health is public health. And now we also want to remind you that public health is community health. And so it's all very circular, and know that the US is the world's leading jailer. And there are many places across the planet that have fewer folks incarcerated and don't have any less safe communities. So what we need is strategic planning to facilitate community services that will eliminate the need for incarceration and to reduce the number of people who are incarcerated for really quality of life issues and for survival. So our action steps are really to look at things on a population-based approach. This is why we're always knocking on the door of CHPPD, and educate and advocate, and then look at how we can coordinate across disciplines. The disparities are, to me, self-evident. There's no one who looks like me in any of the facilities that I've been to across the country. Yeah, there was 2 women, 16 years in Rikers Island, there were 2 women who looked like me. One had been convicted of embezzlement, and the other one was a mom from Staten Island whose family decided to teach her a lesson and let her serve the time in Rikers instead of putting her in a treatment program, I called them. And so the inequities are this overrepresentation of people of color, mostly because of the systemic inequities in our communities. Generations of Black men with limited SES are the primary population in the facilities. This incarceration people think of as being such a huge problem, but it has collateral consequences as well as really isn't the whole story when you look at parole and probation. The majority, there's something in the neighborhood of 20% of folks who are in correctional jail facilities where people are held pending awaiting a hearing are actually there due to technical parole violations. So that for the most part means they missed an appointment. And when we're going to share with you where some correctional community collaborations have happened across the country, but just think of that in the context of there being over 7,000 facilities where 2.3 million people are housed on any given day. And that these collateral consequences are directly impacting people of color and also have prevent people from being able to participate in voting, for getting access to housing, education, employment, and other restrictions as a result of having a history of incarceration. So I'd like you to think about where your where is in the US. Know that this is the total incarcerated population, but pay closer attention to the jail, pretrial jail incarcerated population, where 75% of the folks have not been convicted of anything, and those who are sentenced, it's for a year or less, and the majority of those sentences are due to substance use issues. So we're incarcerating people for health problems. And know that we talked about this earlier, but policy note PCN 18-02 makes it very clear that the use of Ryan White funding for medical services and support, including transitional care coordination that we're going to speak about, are all related to, are all fundable in terms of facilitating continuity of care from incarcerated facilities to the community, and all of the rates of all the things that you would think just when you write the numbers. It's so astonishing, but all of the rates for any public health issue or any communicable disease issue or any issue related to chronic and communicable disease, if you're not addressing the issues in your local jails, then you're missing probably the majority of the population. I thank John Miles for this diagram and for reminding all of us that it's all connected. And if you don't have your correctional facilities in your network, then like I said, you're missing a big part. No longer using recidivism as a word myself, but when folks are coming and going in and out of correctional facilities, we are likely not successfully accomplishing the ostensible goals of punishment and rehab. And I appreciate this quote from Dr. Carmona. COVID impacted the incarcerated at a higher rate. We have an equity task force. Thank you to Homer Venters, a mentor and friend, and the others who have come up with a policy statement that does in fact call for action. We're grateful for that. And for my colleagues at the National Commission on Correctional Health Care and its affiliates at the Academy and Journal for adopting the use of first-person language. Jackie and I sat down and came up with a list of words to avoid as well as words to use. And when you provide this slide that's set out there, just do us a favor and share the words to use. So thinking about trauma-informed care and some of our conversations for tomorrow, I just want you to think about healthcare and how it's provided in the community setting. If you ask someone to have a seat in chairs, just keep in mind that the last time someone asked them to sit in a chair, it might have looked like this and smelled in a way that is not what you would want in your community health clinic, and know that you may be unintentionally causing a traumatic experience for folks who in fact have some of the highest rates of traumatic brain injury in the country. And all of us know the benefits of collaborating across systems, and I want you to keep in mind the correctional system being a place where you're going to run into folks with the most vulnerable populations, unstable housing, and so on. So creating a jail linkages program, working in collaboration between community services and corrections is what we're looking at, both at the client level, program level, and systems level. So in case there was any doubt that I am a social worker, we're always thinking on these three levels and concurrently. And if I didn't warn you to expect the unexpected, I would be amiss of letting you think that this isn't challenging. It is. But also there's nothing more rewarding than working with the folks who everyone else is saying put them behind bars and forget about them, and know that's not it's not okay, and it's not where we need to be in terms of moving forward. So we created this model that links people from one hard cold system on the left, in this case the jail system, to another maybe rule-based system. Community-based services tend to be in tall glass buildings. Maybe you have security at the front as the first people to meet your people coming home after incarceration. And we think of this circle in the middle as a hug. We call it a warm transition, and you can download that information. We have peer-reviewed articles, and know that this was one of the studies that was provided over time. and showed a very clear link between our intervention, which included advocating for folks to get into alternative to incarceration programs or to be released to nursing homes if that's the case, instead of continuing incarceration. And you see that in the release with a plan section of this diagram, as well as linkage to care rates. This was measured at 6 months from incarceration to 6 months after. Jackie says, you have to be an activist. It's like, who has to be an activist? Well, the client has to be an activist, so dealing with parole, probation, community services, and all kinds of systems issues. The workers have to be activists, identifying and coordinating among and between, and the systems need to really work together in the same way. So at every level, what we need is coordination and communication and assistance and support. We do have some tips here about when you do reach out to an attorney, you don't necessarily want to hand a medical summary over to a district attorney certainly without consent or without touching base with the defender. And you want to make sure that you're protecting health information, but you also may find out that there's only 3 questions they need answered, and it doesn't take 3 months to get a health record in order for that to happen. And Jackie will tell you that while all of this seems daunting, it can take just one individual to initiate and one team to sustain it. And we've done this across the country with great success. We do have a measure of linkage to care, to primary care after incarceration as the goal outcome for the evaluation, but no one was going to the doctor if they didn't have medical case management, substance use treatment, housing services, and court advocacy. The folks were interested in transportation, despite us being the largest city in the world with the great public transportation system. Folks were being released in the middle of the night and put in a place that did not necessarily offer the types of services that they needed. So we do appreciate our one-stop partners and the Fortune Society and other reentry service providers, One Stop Career Center, and more. The outcomes speak for themselves in terms of the reductions, not only in the clinical outcomes that you're expecting, but also in emergency department visits, homeless shelter stays, and hunger. And in fact, the Department of Correction said thank you. The Department of Homeless Services said thanks very much. This New York City's Office of Management and Budget said we want the one that saves money, and replicated and expanded the program to pretty much across the entire New York City jail system for all vulnerable populations, because it not only saves lives, it saves money. And so now I want you to remember the map of how many jails and prisons we have, and I'm going to share with you the couple of dozen or so locations where we have a public health model for correctional health. The SPINS Correctional Linkages initiative was at 14 sites. We had a couple of sites through the SPINS Latino work and workforce initiatives. Coaches has a handful of locations where they've implemented pilot projects. There's 3 locations that replicated our original New York City model in Camden, New Jersey, Raleigh, North Carolina, and Las Vegas, Nevada. We've replicated it in Puerto Rico in hybrid facilities, so they're not jails or prisons. Folks are detained or sentenced or whatever. It's all based on location. And we have 3 locations for ACOJA where we'll have PowerPoint, we'll travel. And but you can see that there are lots of areas that have correctional facilities, but do not have this type of enhancement services. We've also done some outreach to save lives with opiate overdose prevention, sharing with our harm reduction partners the training of visitors coming in and out of the jail with study outcomes showing that 14% witnessed overdoses, and 10% of the folks that we gave the 75,000 doses to administered at least 1 dose. So this is low hanging fruit, very cost effective, very highly effective in terms of saving lives. Linkages to care and documenting them is key to being able to show that the program works. And we've disseminated this, as I said, with outcomes showing 76% virally suppressed 6 months after incarceration. They had a little bit of a different way of measuring linkage to care than we did in the New York City model, where we did not include folks who had returned to the jail in our denominator. If they hadn't had the opportunity to be linked in that first 30 days, we took them out. And in this initiative, they left folks in, and if they didn't link because they were in jail, they were counted. So a little bit of a different denominator, but the viral load suppression is hard to argue with. And then we provide here for you in a way to think about your system, your site, and what kinds of things you might do in order to check let's say this, if you can check most of the boxes on the left and most of the boxes on the right, we have tools and tips and resources and training to teach you how to go about the work that's the circle in the middle. So now we're going to ask you to go to the poll and tell us now, not just how comfortable you're feeling about this issue, but what's next in terms of what you think that you might be able to do in your location. What relationships might you need? How can we introduce you to folks? And know that without the single payer healthcare or eliminating the Medicaid exception, the gaps in access to care is not going away. And I leave you with this thought that was planted, a seed that was planted by Khalil Jabbar Muhammad, who came and did a talk about health inequities with our correctional health staff. And he said, it's in the conclusion of his book, Condemnation of Blackness in America. He said, we know what to do. We did it for my ancestors, for white Europeans. We took immigrant off of the census. We know what to do. The question is not what to do. The question is, will we? And so I'm encouraging you to join us to look at some of the resources through the American Public Health Association and others. And John and myself and Tom Lincoln have written a chapter, which we're looking forward to seeing the galleys in next week. And we're looking forward to having you all read it sometime soon. And I'm going to say thank you very much. Questions? Let's see.
Thank you, Alison. So yeah,
almost back on time.
we're almost back on time, and we go a little over. We may dig in a little bit into the membership engagement, but that's fine. I think right now is a good opportunity. We had two great speakers. We did have some questions that happened throughout the meeting earlier for Whitney that they'll actually answer later on. But I think one question that was for Whitney was on those maps you were showing earlier. You were showing the differences in equities. Do you know how those were calculated? Were they comparing Z-scores or something like?
Great question. Anthony asked that, and I did answer him directly in the message. Okay. But just for everyone else, again, I said it was a very limited study. The Communities Health Foundation, when we go to the annual meeting with them, they have like an annual Dallas meeting that's directly with the Community Foundation. They said that they're going to release more data on it. I haven't seen, and I also really haven't checked in because of COVID. I know that when COVID happened, Communities Health Foundation had to shift their focus into responding to the pandemic because they provide a lot for our community. So what they did is they took census data, state data, and city data, which I know, living in the state of Texas, is very limited. As we saw, they didn't include immigration data and LGBT data, which is classically not taken in our city nor in our state. But they did use census data, and it had to be census from the previous census, not this recent census, which is why I'm excited to see what they release next year to see if it's has more information for us. But they did not take it from Z-scores. They did not use any other type of like healthy people data or any type of data like that. Which is why I find it limited, and that's what I kind of found it peculiar. So when I was in that meeting, a bunch of us from Parkland were kind of like, "Why did you use this model and not a different model?" Because we're all healthcare workers, and we're used to seeing the healthy people data and all these different types of data sets that we have access to for when we're making these comparisons. And they said they wanted to make it as transparent and easy to read for the city's constituents. So this whole entire packet was really meant for the city of Dallas to read. And so they're trying to take into consideration people of different ethnicities and different educational levels, those who have worked with data before and those who haven't. So hopefully in the next year, by 2022, Communities Health Foundation can re-release either a new report or give us some of that data that they are using so that we can really kind of see where these inequities lies, because you can't just compare white populations to Hispanic populations. You really do need to see white, Hispanic, immigration, LGBT populations compared in order to get a full idea of what inequity looks like. So great question. Thank you, Anthony.
You still have your hand raised, Anthony. Do you have a follow-up? Oh, we can't hear you. You are unmuted, but for some reason we can't hear you. So yeah, if you could type it, we'll follow up. Ah.
You can always put it in the chat and we can answer it again, or I can email.
Alison, I did have a question for you. I really enjoyed that octopus graphic and the various roles, players that need to be involved. My thought was, are there any of those stakeholders or individuals that are most important or more important to others, or is there any like key ones that must be touched, or are they all equally important?
Yeah, I think the collaborations between your local health department and your local jail are really essential. Certainly, you're not going in terms of the linkages to care for community alternatives to incarceration. You're not getting to go without the defense attorney, the district attorney, and the judge kind of agreeing for folks who are pending hearings and awaiting trials, and you're coming up with alternatives. So I think the criminal legal system needs to be working together with public health, and then community case managers in whatever form in the Ryan White community has demonstrated the great success of this, as well as peers and peer navigators and folks themselves who really know. I mean, if you want to know what the right first step is, ask the person who's taking it.
Both parts were great. Yes, thank you, Anthony. Any other questions from the audience? So
if not, I have a relational question for Alison. So Alison, you're talking about, I mean, we're obviously all dealing with COVID still, which I know is a sore spot and we don't want to talk about it anymore, but we kind of still have to. And so we're talking about how, well, not really, actually not with COVID. This is an environmental question. So the state of Texas got in trouble last year with their private incarcerated facilities. So specifically in South Texas, they don't have AC. And so, or they had really bad AC. And so there was a lot of, during the middle of the pandemic, a lot of incarcerated individuals getting very sick from a heat wave. And currently right now, this week, we're in our first heat wave of the year, which is late for, well, not really late for Texas. It's normal for Texas, but still, I don't know where we stand on those, if they actually fix those issues. And I don't even know if it was technically legal or not. I didn't really follow up with that news article that was released, but I assume that you might have a little bit more to say on how those two, how we cross-section on that.
Yeah, in fact, we did a whole community collaborative on and several presentations on COVID-19 and correctional facilities. So there's a saying, if you've been to one jail, you've been to one jail. And if I honestly, I feel like if you've been to one jail on one day, you've been to one jail on one day. And so the reality is that these facilities, regardless of whether they're private or public, are not regulated. And the National Commission of Correctional Healthcare provides guidelines, but there's no oversight, there's no dings. You can maybe get a certificate that says that you were compliant one day when the person came out, and I encourage folks to do that, but there's no standards. There's other than Estelle v. Gamble, which says that you have the right to healthcare, and what level of healthcare and at what point in time is anybody's guess. This is why there was such a big cry for at the APHA 2020 late breaker to reduce the harms of incarceration, including reducing the number of people who are incarcerated. And there was a great effort starting on March 18th of 2020 to try and reduce the population, particularly of pretrial detainees. And that was imminently successful in terms of reducing the population in jail facilities, though not prisons, particularly not New York prisons. But that population has continued to climb, and while there have been significant reductions in some areas, for the most part, we remain an incarceration nation. And so whatever you think should be done from a public health perspective, take your dollars, rub them together, and make a third one, and bring those approaches into your correctional facilities, and you will be serving the highest risk, highest need population without having to go to any zip codes or do any maps. You can be pretty sure that if you're addressing the needs of the folks in your local jail, you're addressing the needs of the highest risk, highest need populations in the country. And yeah, there's no the air conditioning, food, people having to pay co-pays for healthcare. There's no shortage of things that just make you shake your head every day, and not up and down.
Right, thank you. That's all I have. I'll stop talking.
Yeah, it's hard. I mean, it is the
it is
most likely the most environment. Just pick a thing. It doesn't actually matter what thing you know that you're working on in public health. You are likeliest to find the population at greatest risk with the lowest resources in your local jails.
Right. I know someone asked earlier if a CHPPD section, if we work with other sections outside of this meeting or other organizations, and we do work with Alison. Alison hosts a great event every year at APHA, a dinner with her organization. I know that we've worked with the environmental health sector, and we plan on doing that, our health section, and I know we plan on doing that again. We've also worked with people outside of APHA. We worked with Black Girls in Public Health, ran a publication and a platform on our social media with them. So we're trying to do more outside of our community, even though our community is very large. And you can see that, like what Alison was saying, like the incarcerated health, they relate to everything, every public health issue, every racial disparity you can find in incarcerated health. And then on my side with environmental health, it touches everything. So there's not one point where you can just stay in one lane anymore. You have to kind of diverse yourself as a public health worker.
I'd also add with the Community Day of Action during APHA, we do a lot of collaboration. We do collaborations in the community, and recently with the California Health Foundation. But we've always found a partnership in the community that we're visiting, and collaborate with them on an event. So we're always looking for collaboration and opportunities, as our section title emboldens us to do.
Yeah, so the Justice and Incarcerated Health Committee's original home was in the medical care section. We reside there still. We asked to join the Community Health Policy and Program Development group because we knew of the great work, and because we're trying to move the needle from having all the conversations about delivering better medical care during incarceration to moving people out of incarceration and into communities where the appropriate care and treatment can be provided, and to reduce those gaps that happen because of people going in and out, like losing health insurance benefits themselves and their families, losing housing, losing apartments, and then so on and so forth. It's just it's a downward spiral, and anything we can do to avoid it with the young folks and in any realm, I think the alternatives have got to be better, and the number of folks that we're incarcerating is not getting appreciably less. I'm not hopeful for the 2020 census to be astronomically lower rates, and you know we need to do better. This is not about safety, right? This is about structural racism. There's no other way around it. And I think we may be at a point now where that's understood, certainly I'm hoping by the folks here, but the more that we just call it what it is, I think the better off we'll be in terms of advocacy. We just have to stop. I mean, there's two, I've shared this a couple times, but there's two things that we've written in our papers. One was on the original jail linkages initiative, where we said that the Chelsea neighborhood of Manhattan was the only exception to the folks coming home from incarceration, going to communities of the highest racial, ethnic, and socioeconomic disparities. So what basically we're saying is that the HIV impacted white gay men who have middle income folks, and so they were the exclusion. And then with the opiate epidemic, it was the women who looked like me and their sons who were overrepresented among the opiate population. But those exceptions actually prove the rule, which is that the folks who are most likely to be incarcerated are people who are brown and black and live in poverty. And none of that's by accident.
Right.
The system's doing what it was designed to do. Do you want me to tell you what I really think? No.
This was a great conversation. And I thank you again, Alison and Whitney, for sharing your expertise and knowledge with us today. I am going to do a little bit of a switch because I do think there are some folks on the call who are logged in but may not be at their computer. And for this networking activity to work well, we need folks to be engaged and to jump in. And so what I'm going to do is I'm going to end the meeting, but then I want folks to come back to the meeting. So if you are hearing this, you know that you need to come back. And the link will still work. And so I want folks, and that way those who come back will be those who are ready to engage in the networking side of the activity of the activity. So come back in 1 minute. All right.